Today on the UnHack channel with me, Drex DeFord.
That's part of our philosophy is make it harder for them to do the low cost, stealthy stuff, force them into higher fidelity channels so that we can catch them.
Hey everyone, I'm Drex and this is UnHack the podcast. Today I want to bring you a conversation that I've really wanted to highlight, and that's Bill Russell's interview with Sahan Fernando, the CISO at Rady Children's. This is one of those discussions that gets right to the heart of what healthcare security leaders are dealing with day to day. It's exactly the kind of mostly plain English, mostly non-technical cybersecurity and risk discussion that we all love to eavesdrop on. So let's jump into it and hear what they have to say. Here we go.
Today, we're joined by Sahan Fernando, CISO, Chief Information Security Officer for Rady Children's Health out of San Diego. I guess out of San Diego and Orange County, it's Southern California now, right?
Indeed. Yeah, we're fortunate we serve pediatric populations for inpatient and outpatient, not just everything kind of south of Los Angeles, but we have patients coming in from all over the world.
Yeah. Children's hospitals are the coolest places on the planet. Now, you don't want to be there for obvious reasons, but it's still, when I was at St. Joe's, we were connected to CHOC Children's in Orange, California. And man, I'll tell you, it was a stark contrast. Like you walk in there, beautiful paintings, it was bright, it was cheery. And then literally our buildings were connected and you walk through a hall and it's like you entered like the 1950s and everything's in black and white. And like, we need to do something with the non-children's hospitals, like hire a painter or something and make them more bright.
Yeah, absolutely. It's funny though that you bring up that story because you and I saw each other only last week in Madison, and Judy Faulkner during her keynote actually touched on that exact paradigm, right? Children's hospitals really do strive to be very uplifting and not let your circumstances affect you. I think there is a lot in terms of your mental state being a part of your healing process and where you're at. And she really strongly put out there, we need to do more on the adult side.
I don't know about you, but if I ever become like a trillionaire, that's what I'm going to do. That's going to be my new, and actually Judy should do this. She's a trillionaire or something. Like she should literally go to every hospital and say, look, I've got some paint and I've got some really talented artists from the local college and university, and we would like to spruce this place. I don't think you can do that, but it would be great if they could.
They certainly lead by example. That campus is top 5 and on.
One of the things that has always impressed me about children's hospitals is how they're able to do so much with so little. They are fairly well funded. However, there's not money dripping out the sides of the walls. And so they're very lean, especially on the IT side, very lean organizations. And like when I was doing work with CHOC, my team of 3 or 4 people would meet with them who represented like another 20 to 25 people, and they would meet with 2 people over at CHOC, and that would be their whole department who was doing that thing. And I would be like, wow, can't imagine, because you have the same issues, right? You have to protect against the same stuff. You have the same attackers trying to get in. You have the same everything.
And I think you touch on an important point there is that even from a patient experience, they have the same expectations. They don't see it as when I take my child to a pediatric specialty that I'm going to have a different experience, a less well-funded experience than when I go as an adult. And so there is that drive and that pressure to ensure consistency and excellence, which I believe our organization really strives for that every day, but it is harder. And I think in California in particularly, I don't think this is that controversial to say, being so reliant on Medi-Cal, the reimbursements doesn't cover a lot of the cases. And I think especially in Southern California where we have some more unique patient loads. And so it's very lean. IT is still always catching up. And then we still run into, I think healthcare has lived so long on big projects, meaning we're using CapEx, and they like the advantages from an accounting standpoint there, but it's so much harder to use capital if it's not directly on hardware anymore.
Right. You guys are an Epic shop, or are you a Community Connect, or what are you?
Very timely question. So the San Diego region is actually a very early Epic customer. We began our implementation, I believe, in 2008 and went live in 2010, but I might be off by 2 years late there. And my old boss was a very big champion of bringing them in. He came in as CIO in 2006 and saw that as a big need. And that was obviously a massive transformation, well ahead of meaningful use or any sort of other incentives. So we actually,
and Epic wasn't necessarily built for children's hospitals. Like, you guys had to help them build it. I'm sort of giving you words, but I've talked to enough children's hospitals that they were like, hey, the reason we were all on Cerner is Epic didn't really pay attention to us until there was some of us on the platform.
I think that's a fair take. Absolutely. It's helping them understand more of those nuances between pediatric care and adolescent care, for sure. I mean, there are differences, and there are still certain modules that we can't use in Epic because it doesn't fit pediatric workflows versus adult ones. And so I know that Epic's a great player.
But still, Epic has made some pretty significant inroads. I assume that Chalk and Rady's will be on the same build.
We will definitely converge onto a single electronic health record platform. I guess now we're supposed to just call it converged health record according to Judy. And I can't say publicly what that will be.
Yeah, nor do I expect you to, but that's what the converged health record, that's what the consumers expect now. Yeah. I'm curious, they announced so many things at UGM this year. One of the things they announced was a single, I forget what they called it, but single MyChart login, essentially. And you have that converged record behind it. So what used to have to happen is I would log into multiple MyCharts and have to see what's going on, or I'd have to, from whoever I'm seeing now, I'd have to request those records, and Care Everywhere would move them all. But essentially, I would go to MyChart through my provider. I mean, that to me was an interesting play, especially in the pediatric space, because you have a lot of specialists and specialties and kids moving from a primary care doc and a health system over to children's back, potentially some people traveling to you guys. I'm curious what your thoughts are on how that's going to change things, or how that's going to change the experience for them.
Absolutely. It's exciting. I mean, I don't think there has been anyone pushing quite as hard as Epic has on the portability side of HIPAA. And that interoperability is really one of those big buzzwords, but it does have meaning and value. I'm really excited for the overall idea. I think the risk management side of me being in information security, the privacy portions and some of the nuances, especially in pediatrics, are going to be the hurdles. And I don't know if that's going to be incumbent on us to fix, or if Epic is going to lead the charge, because state by state, we're going to have different regulations and governing laws. And so I know that is an active discussion topic among kind of chief information security officers and privacy officers right now. Is this sounds great. How do we do this in a way that we're not violating another state's laws? So it's really great to have that functionality. And we see more and more folks that leverage CareLink, right? Really a more coordinated care team. And I think, especially when I travel quite a bit, I have my background blurred, but otherwise you would see so many planes and such. And being abroad, the reducing barriers to relevant information for me, if I were to need care, is a really powerful idea, right? If I had allergies, things, and basic things like the MAR, being able to reduce barriers to sharing that information is really great. And they've obviously been really pushing on the TEFCA side of things as well. So there is a cohesive thought, I think, there on how do we empower patients to have more agency over their data, their records, and really more ownership of their care plan, and being able to work with the care teams that they want to and need to. I really see that as very empowering, and I really hope it does play out.
I love the fact that you brought up portability when talking about HIPAA. I think it's the forgotten P in HIPAA is portability. But man, I also love what you're talking about there, because when I was at St. Joe's, we had Southern California, Northern California, which was easy. Then we had Northwest Texas. We had Lubbock, Texas. And we had to navigate some of that stuff. And it was interesting. Like, a child is considered a certain age in California. It's considered a different age in Texas. The access from the parent was handled differently in both those states. Like, when does the parent stop having access to the medical record and the child has? agency over their own record. We had a distinction in that we owned those hospitals, so we had to navigate that. So you still have to navigate the sharing outside, even if you don't own those hospitals. You still have to figure that out.
I believe we do. Yeah. I know that for us, we have a very clear policy that aligns with California law in terms of when a patient requires a proxy access versus direct. And there are even certain results in other parts of their record that are more controlled, let's say, to protect as they become a teenager and more involved with their own health, that they have a little bit more control over that. So that's actually, I think, an ongoing, let's say, not burden, but an ongoing workload for our health information management teams is kind of the appropriate release of information and validating proxies and guardianships. There's a lot on, I think, that people don't realize on the administrative side to ensure proper access to different parts of the controlled information. It's really quite fascinating.
Yeah, just out of curiosity, I'm going to throw this question out. You don't have to answer it if you don't want. What's your data retention policy?
It's hilarious. I actually had a very direct conversation about this about 16 hours ago. So
it comes up in so many of our 229 meetings because people are like, what's your retention policy? They'll go, forever. And I'm like, seriously? They're like, it's so all over the board that it's just forever.
I can actually answer this to a meaningful level. So
awesome.
With Epic, it's essentially forever. Technically, once a child reaches the appropriate age, which I believe is 23, you can start rolling off, I think, 7 years worth of history, but we don't. So we do keep all the health data essentially forever in terms of Epic. We have a business records retention policy that is completely separate. For email and those sorts of communications, it's currently 2 years or 3 years. I think it's set for 2 years, and that's enforced in a few different ways. It's spent about 10 minutes on retention policies and why that's a burning topic for everyone, because you got to mention AI in our conversation, right?
Right.
A lot of people are using Copilot and other transcription services, and they aren't thinking about, do I actually want those transcripts existing for 2 years as a part of my records retention policy? So I think thankfully technology exists to facilitate a more nuanced approach, but there is some risk there, I think, from a legal standpoint.
The records represent the attack surface, right? I mean, if I get into your email and start tooling around, I was talking to one CIO. Interestingly, a CIO talking about security is awesome. And he was saying that they were undertaking a process, and it was a research institution. They were undertaking a process to go through all the historic email and identify the PHI and PII in all those emails and strip them out and leave markers where they could click on it and go to get it. But the actual PII and PHI that was in the email system out. And I'm like, well, how pervasive is that? And he goes, well, the farther back you go, the more pervasive it was. It represents an attack surface. I mean, that has to be one of the biggest challenges for you guys, is the attack surface appears to be only getting broader. And it's people want to work from different locations. That increases the attack surface. Therefore, they want remote access to certain things. They want data sharing with certain entities. If your user community is like ours, they didn't want us to delete any email ever. So 3-year retention policy would have been a fight with somebody, I'm sure, within the health system. It's kind of crazy.
It still comes up for sure. But that thankfully is, if you would like an exception to policy, I'm happy to refer you to compliance, legal, and corporate leadership, because that is not my decision to make. I'm just here so we don't get fined, is usually my response to that conversation. And the fine thing, I think, is very relevant to when we talk about risk and attack surface, right? There's the two risks I really think of are around, one, this type of risk when we think the amount of records that are in kind of unstructured locations like email and chats, things like that. When a threat actor gets access to an email inbox, right? If you can't prove that they didn't go through things, then all the records are considered in scope, and that starts to become a part of your, well, these are the amount of records that you have to report to the OCR as breached, right? And that adds up quickly if you have a trauma coordinator that sent out a spreadsheet of 600 patients, right? Where that can add up over weeks and weeks very quickly. And so those fines are no joke. And sometimes that's, from my recollection, pretty equivalent to when you look at downtime from, let's say, ransomware, lost revenue, direct costs from recovery, things like that. In either case, you can be talking about millions. And in both cases, then investigations, corrective actions, action plans, things like that. And so
I want to walk people through your role. I mean, without being too specific. So one of the reasons we don't get too specific with CISOs is we don't want to reveal too much, but let's take something that happened last year that was pretty widespread, and that is the CrowdStrike outage. So with this, it's one of those questions, like, do you know where you were when the first astronaut landed on the moon? This is like, do you remember where you were when you found out about the CrowdStrike thing? And did you know it was CrowdStrike right away, or did you have to go through that period of, I don't know if this is a ransomware attack or what this is?
I did know it was CrowdStrike very quickly. I do have, thankfully, contacts and friends in APAC region, and we work very closely with Health ISAC. And so they were very much on point for, hey, this is going on, setting up information sharing channels and starting to try and connect people with resources on, here are some potential workarounds, fixes. Really, I think they took a really strong lead for the healthcare sector on facilitating communications with CrowdStrike, with Microsoft, and going from there. So that, it's incredible though, because I think we've matured so much on the IT and information security side, where there's still some people that say, oh, monthly patching every month is really still a scary thing. I think CrowdStrike handled it incredibly admirably. They owned their mistake. They were very transparent. They used their resources to help out different organizations. And they even, I think, they took it so much in stride that they accepted a Pony Award at, I want to say that was at DEF CON, for essentially causing such a large outage. So they were very transparent. They owned it. But I think it really, like I said earlier, 2024 is, do we understand risks in our digital supply chain? And so between Change and CrowdStrike, Health Sector Coordinating Council is really doing some great work on how do we map out our dependencies where we have key concentrations of risk from a supply chain standpoint, and how do we empower different members of the healthcare sector to start applying that logic to their organizations. And as a provider, I really think we have to continue looking at that, right? Information security has really evolved from just how do we keep threat actors out to how do we manage systemic risk related to technology. And availability is core for us as providers. I mean, if a bunch of records do get breached, that's obviously a very bad thing, but patients are still getting treated. But if I have, and I do run an annual tabletop with our operations folks every year, one of the first things we do when we kick that off is, okay, we've got kids on the tables in the OR. This is our inpatient census. Are we still running ambulatory clinics? And if you really think about it from an availability downtime standpoint, that's the risk that really bothers me.
Yeah. I tooled over here to LinkedIn, pulled up your profile. Rowing? You were a men's rowing coach for Division I athletics program?
And first practice of the year was yesterday, actually, as a volunteer.
As a volunteer.
Yeah.
I was going to say, you don't have two full-time jobs?
Thankfully, not full-time. And they're understanding that as I've gotten older, life shifts around and priorities. But I went to a Jesuit high school in Phoenix, Arizona called Brophy College Preparatory. And so that's how I came across Gonzaga. And I just also happened to want to row in college. I rowed in high school, which I know sounds a bit strange, rowing in Arizona, but there is a scene for it there.
Oh yeah, it's right there. Well, is it in Tempe? Is that what you're talking about?
Town Lake, yeah.
Yeah, I mean, actually, it's really nice area, I think.
No, it's gorgeous. It's gotten better. About 15 years ago, though, when I was working there, the dam blew up and it was an empty lake bed for a couple months. So it was a fun morning. But
yeah, how'd you practice?
Well, since I was working, I was there at 4 a.m. and we had to start making sure people, their natural inclination is, oh, empty lake bed, let me go in. And people obviously have been throwing things into the lake for years. So there was a very big safety hazard there. A lot of glass, a lot of sunglasses, cell phones, fridges. But we also had to worry about humans that were camping downstream of the dam, ensuring no loss of life. So yeah, that feels like a lifetime ago. But I do love to continue to coach. I think one, being in a leadership position, it helps me to continue to hone those skills, and coaching college athletes as I continue to grow older, that allows me to ensure that I'm still able to work with the next generation and understand a bit more of how do they think, how do they see the world, how can I ensure that I know how to communicate with them? Because again, being in the CISO role, you have to communicate with a very disparate group of stakeholders. You have to be able to talk to the IT folks that are doing the day-to-day work and explain risks and understand what they're saying, and also talk to the CEOs and the board and be able to essentially fly the plane at 35,000 feet as well as 10,000 feet and kind of seamlessly switch, but still be in the same flight. And so it's been great. And it obviously keeps me away from the computer for a few hours. And thankfully also lets me go to Gonzaga basketball games.
That's actually kind of sweet. So talk to me about Health ISAC a little bit. So you served for what, a couple of years now?
Yes. Yeah. It will be 3 years this December, and I'm actually up for re-election this fall.
Okay. Well, hopefully we'll help your reelection chances, but I'm curious. 2.5 years ago, we were talking about a really stringent set of rules coming in that health systems were all worried about and that kind of stuff. Has that stuff like evaporated now?
In some senses, I think yes. The CPGs, I think, is what we're referring to. And those are really strong security principles. And to our earlier conversation, the disparity in maturity levels for different people that are under the purview of HIPAA as a covered entity, that's where I think we've seen a lot of debate on, should we move forward with this? Because if we're doing all stick and no carrot, if we very candidly look at right now, the paradigm is a reduction in funding from the federal governments. And so to try and increase funding at the same time, mandate increased funding in certain programs, that's a really difficult proposition. And so I think there's a timing aspect of it. I think we still need to continue to push each other to mature and evolve and ensure that we're handling risk, which is, I'm not just saying this because I'm on the show, opportunities like the 229 summits are so valuable for that, because you get the opportunity to say, here's something I'm struggling with. How are you all handling it? And really kind of that iron sharpens irons approach. And you hear about things that you wouldn't have even thought. I still have on my desk, a notebook from each summit I've been at with just pages of notes that I need to go with this, and I should think about this. And if that idea of information sharing, the community aspect is so critical in our sector, right? And we're not competitors at the end of the day. We are all in this together for our patients. And if I go down, I know that's going to affect you, right? I mean, when providers go down around us, we have to coordinate with them.
I'm sure somebody's going to be upset with me saying, well, health systems didn't really care about security programs back then. But I do remember in 2012 coming into healthcare, and I mean, it was established by then. I mean, we were looking at security and that kind of stuff. But I came in from outside the industry, and I just looked at them and I'm like, we've got to increase our security spending by 5x, maybe 6x. And they looked at me like I was insane. I'm like, no, you don't understand. We really have to increase our security spending 5 to 6x. And we need to hire some people. We need to change our practices. We probably need to stand up a SOC. And they're just looking at me like, but we don't have that money. I'm like, yeah, we're going to find that money, because you can't operate a hospital and the data that we're dealing with without putting all these things in place. And the thing that has struck me at the 229 conversations is the amount of money we were spending, and I still felt fairly vulnerable back then. And if I didn't feel vulnerable, every time Deloitte came in and did an audit, they made me feel vulnerable. But there's systems doing it for far less money with far less resources. And with Health ISAC, you have to consider all of those. You have to consider the well-funded Mayos, and then you have to consider the critical access hospital in Wyoming. The breadth of that is staggering. Like, how do you bring people along? You talk about carrots and sticks and best practices and sharing best practices. I love the security group in our country. I love the most because you guys are very connected, sharing stuff all the time, because we don't really compete on cybersecurity and privacy and risk. We share those things so that we can get better. but still the disparity between some of this is pretty broad. I'm curious how the conversations go at Health ISAC to say, look, is there a middle ground that you shoot for and say, well, let's shoot for the middle? Or do you just go, no, we got to shoot for the top, but we got to figure out a path to get everybody there? The calculus on that is really hard.
One of the main things it excels at, though, is it creates the space, again, like Teach9, to have those conversations. And, sometimes it feels, I think, almost like imposter syndrome, where I hear something and I think, wow, that's incredible. And you do have to take a step and realize, hey, we aren't Merck or Pfizer. Maybe one day we could get to something close to that level, but relative to, if we looked at it from an economical value, relative to what we bring in, we're doing pretty well. And that's, what's the phrase? Comparison is the thief of joy. I think you can still be satisfied with that you've done a good job with the resources allocated and still have that pursuit of perfection, because that's part of the fun, I would say, is how do we make this as good as possible, knowing that in a couple of years, what that means will absolutely have changed. And so that's, I think, one of the cool things with technology and security is that because things are changing, you don't get to just sit complacently on certain things and say, well, we solved that. Some things you do, and that's great, but you always have a new challenge to address. And so to your question on how do those conversations go, I'll try and think of a really good example here where, for us, where I found the venues of the ISAC, the summits, working groups, things like that, hearing directly from my friend Terry Rice, who was at Merck at the time, his experience through NotPetya and being, I don't want to take too much of his story. It's a wonderful story, but he was on Machu Picchu when NotPetya hit. And just that whole story of how they handled the multi-nation incident response and recovery and what they did from an after-action standpoint, and how that also fed into how they approached reporting and not just data lake, but their whole strategy on how they took security telemetry and turned that into more executive facing things. Those are not always things you will think of on your own, but they inspire you to think, what can we do? And those are things to maybe add to our roadmap. And I would say similarly, I know that we have done a lot on embracing the zero trust paradigm, and I'm really proud of just all the work that Rady Children's across the board. It's not me, it's the entire team buying in and working together across all of IT, and really ops also giving us the grace to do a lot of work. I actually have a talk that I'm debuting this year around that whole journey, because when I think about where we started and where we are now, we've continued to mature a good program into continuing to make it even stronger. My predecessor did a wonderful job. We're still in contact, actually, and he left me some really great starting blocks, especially for what was next. And we get to share on that journey, how we've approached identity security. I think we really embraced the idea of we need to secure identity. When we read forensics reports, that is, lateral movement and privilege escalation are still all identity-based attacks. And we need to secure that. We need to tie more to your identity as a result, because we want to try and balance the friction with convenience that security tends to introduce. And so those are some things that we're able to share with other organizations, both larger and smaller. And the nice thing with, I think, most CISOs is just because they're bigger, they don't assume that they have it all right. And they will absolutely take your opinion as a small organization. We're all in it together.
That's awesome. A lot of these podcasts have gone to the really personal. They'll ask you, like, if you were stranded. I was just talking to somebody yesterday. One of their questions was, if you're stranded on a desert island, what's the 5 albums you want to have with you? And not that wouldn't be interesting and fun to do with you, but we've come up with the escape room concept. And here's your escape room question. And you're familiar with an escape room, right?
Oh, yeah.
All right. So we lock you in this room. Here's the challenge that you have. And this is a very real challenge. It happened a number of years ago. It was a ransomware attack. And I'm going to put you as the Community Connect host for this. So the Community Connect host, CIO, got a phone call from their Community Connect partner health system. And they were experiencing all sorts of anomalies on their network, and systems were starting to go down. and that kind of stuff. So the CIO who's not at the Community Connect partner site has to determine, is this ransomware? And if it's ransomware, do I disconnect our link between the two, which will essentially take their EHR down? I'm curious, what we're trying to get to here is, how do you think through these things? How do you process through those kinds of challenges? Because hopefully you won't have to face any of those, but my guess is that's the world you live in. So
It is. And being the Community Connect poster, we've run through those in tabletop form for sure. So for me, I think that starts with, it's not an InfoSec decision in a silo. This is a business decision, and we need to ensure that the clinical folks, the operation folks, they're all in alignment, especially from a leadership standpoint on, here's what we're proposing. Can we move forward? Now, sometimes you need to move fast and accept that you might have had it wrong. Because if you shut off the link, for instance, at worst, you turn it back on and you apologize, right? I think that's part of your leadership gut instincts, depending on what you hear. When I hear anomalies and things shutting down, I would err on more towards that side, but it also depends on what does shutting down mean, right? Like, if going back to your question about last July and CrowdStrike, right? A bunch of blue screens of death, essentially, I would probably start with, well, we have to assume breach until we have evidence otherwise. Now, in that case, we knew right away what was going on, thanks to Health ISAC and our friends throughout the world. But if you really are embracing that zero trust paradigm, it is seeing compromise until you can essentially disprove that hypothesis. And so a lot of this is proactive work, right? If you are drilling and you are informing your stakeholders of potential risks and how you would manage them, especially when they are realized, it's less of a surprise, and you have an alignment from the beginning on the what, the why, and the how. And that's a big part of, I think, the CISO role is, so again, risk management, proactive and reactive. So you have basically the buy-in to have certain actions already authorized. And so in that situation, I would say, yeah, we are on the side of turning down the link. If we need to do that physically, or it's just cutting off VPN tunnels or MPLS circuits, great. But we've at least had that conversation. And if we haven't, we need to ensure that we have the right people in that call to ensure that we know, what are we doing? What's the impact, and who do we need to let know, and how that cascades down in terms of the staff, in terms of the patients. Are we still able to move to downtime procedures and continue providing care, right? What are we needing to cancel? Do we have a means to contact patients? What is our public communications strategy going to be? Who's on point for that? What are we saying? Is it legally approved? Are we going to call insurance? Are we activating IR retainer? Do we want to do that? There's a whole bunch of nuance there. And who is on point for investigations? What's the cadence of updates? Things like that.
So let me move you forward about, I don't know, a couple of days. It was ransomware. You move it forward a couple of days. They had disconnected it. Now the question becomes reconnecting. So what's your thought process on reconnecting? Is this also something that you've played through and said, hey, look, if somebody's been ransomed, these are the steps they're going to have to get through before they get back on?
Yeah, we have through West Tabletop and more other places.
Policy, right?
Years. Yeah. And so we don't put a formal policy out on this because we haven't seen a need, but it's a generally understood cultural stance that if we need to reconnect with someone who has been hit, we basically want a third-party assurance of this thing has been cleared forensically. At that point, we're really talking about the legal liability from my standpoint on, I don't think that any other party would say, oh yeah, we're fine, right? And willingly give you an
yeah, we're fine. Just turn it back on. Oh, okay.
Right. But I think that independent attestation also is a bit of us shielding ourselves so that we can say, well, we had someone independently come in, or they had someone independently come in and clear it. So we did our due diligence, and should something happen, we can show that trail of, here was the rationale and the risk management process. And obviously the risk was never going to be zero. They could have had some other infection that hadn't taken hold yet that's completely separate. And so that's our normal process. And so for instance, last year with Change, we had blocked all traffic to them. We'd shut down the limited scope that we had there. And we We're a part of the very large group planning for give us official updates. We want forensics, things like that as we resume whatever we are allowing. And so I think that allows you a bit more nuance on investigations because they're never going to be the same. And I think even with ransomware, it's, well, what was the scope? Where are you at from a containment standpoint? Where are you at from a recovery standpoint? And that then you get into the nuances of how good was their DR? Were they scanning their backups? How long back are their backups? Where are they restoring from? What were the relevant tactics, techniques, and procedures? Because I think that informs their backups.
That recovery took long.
Yeah.
I mean, based on the impact on healthcare, it was pretty long. The metric which always shocks me is time on network or time on network.
The dwell time.
Yeah, dwell time. Is that what it is? The number, well, it's getting a lot better. But man, some of these attacks, it's like they had been on network for 60 days, 90 days. And you're like, oh my gosh, that's scary because the amount of movement you can do in 90 days is pretty significant.
It is. And as dwell time has reduced, the problem is they understand, well, we're just going to need to move faster. So dwell time reduces, but also the time to impact has also correspondingly
reduced. Right.
And there's trade-offs with that, I think. Because they're trying to move a little faster, that gives you more detection opportunities. But to our earlier conversation on why we went so heavy on identity security is exactly these sorts of reasons. I think you have really high fidelity telemetry and alerts and detection controls in place so that if you start forcing them through high visibility channels, you shut off proactively those kind of stealthier tactics, you have more opportunities to reduce that dwell time and prevent impact. That's part of our philosophy is make it harder for them to do the low cost, stealthy stuff, force them into higher fidelity channels so that we can catch them and you can kind of continuously refine. And detection tradecraft is another one of our passions that we look at a lot. And for a smaller place, I think sometimes we get a little too eager about it. We have obviously some internal SOC functions, but we have partners that help. But as they continue to get a bit more aggressive, there's things that are, like I said, good about that for us and maybe a little bit difficult for us. And I think we've seen that play out. I've given some talks over the last year and a half over where if you can catch someone early, you can do quite a bit. But when we look at forensic reports, one of my favorite walkthroughs, I was actually an attacker. I don't think it's online anymore, unfortunately, but a threat actor actually wrote, this is how I hacked into a spyware company. And they walked through kind of a multi-week approach of, well, they started with something very esoteric where they put in a 0-day on the external router. But then from there, it was, well, here's where I looked at first from a reconnaissance standpoint. And then I found identities that I could compromise. I mean, this is going back. They compromised the BlackBerry service account at this hacking company or the spyware company. And it was just that sort of tradecraft, I think, is very much on my mind when I think at a higher level, what are we looking at? Because administrative controls are really great, but the technical controls that we're accountable for as well on the prevention side, those are things I think of. How do we really ensure that we're putting up the right gates and different types of gates and moats and other sorts of defenses varying so that the layers are helpful, but still let the right stuff through.
Sahan, I want to thank you for coming on the show. Everybody wants to go on with Drex now since he's a lot cooler than I am. And I appreciate you coming on this show and talking to us. I don't want to be one of those former CIOs that doesn't talk about security because it's such a critical aspect of everything we do. And I appreciate you sharing your experience and wisdom with the community. Thanks.
Thank you so much for having me on. I'm glad we didn't only talk about security stuff. It was a lot of great conversation.
We can. Next time, we're going to talk about rowing and get into much more detail on crew and whatnot. So, all right. Hey, thanks, man. Take care.
Thanks for joining UnHack. Remember, we're not alone in this. Every healthcare leader needs a community to lean on and learn from. Join our community at thisweekhealth.com/subscribe and share this not only with your security crew, but with your entire leadership team and staff. Together, we're stronger.